Usually when we talk about like a medical diagnosis, there is this expectation of absolute precision.
Right, like it's just black and white.
Exactly. We treat the human body like an engineering problem. Like you fall, you break your arm, the x-ray shows that jagged white line on the film, and the doctor just points to the screen and says, well, there is the problem.
Yeah, it's highly visual. It's categorized.
And honestly, it is comforting.
Oh, absolutely. I mean, we rely entirely on the idea that seeing is believing.
Yeah.
The whole medical model is built on objective visual proof.
Right.
If a provider cannot see a fracture or a tumor or, an infection, the default assumption is often just that the patient is healthy.
But then you step into the world of pelvic floor health, and suddenly that x-ray machine is, well, it's fundamentally broken.
It really is.
We are looking at this diagnostic landscape where what you, the patient, feel on a daily basis and what your doctor actually sees during an exam might completely contradict each other.
Which is incredibly frustrating for the patient.
Exactly. So welcome to another custom-tailored deep dive designed specifically for you. Today, we have a massive stack of research to get through.
Yeah, we've got joint reports from the International Continence Society and the International Urogynecological Association.
Plus the Developus clinical study, which is fascinating, and clinical practice guidelines from Mendwell Pelvic Health and the Mayo Clinic.
It's a really comprehensive stack.
Yeah.
And it highlights just how muddy the diagnostic waters can get in this field.
Oh, for sure.
We are bridging biomechanics, subjective patient surveys, and very rigid anatomical guidelines to understand why the medical system often, fails to diagnose what women are actually experiencing.
Right. And our mission today is to tackle a highly searched but really rarely openly discussed question. Can anterior wall weakness actually feel like vaginal laxity?
A huge question.
Because there are thousands of women out there who experience this profound sensation of looseness or just a lack of internal support, especially after childbirth or during the transition into menopause.
Right. They go to the doctor, they describe this feeling, and they're just told everything looks perfectly normal.
Yeah, it's completely invalidating. Okay, let's unpack this.
So to understand how a provider and a patient can be having two entirely different conversations, we really need to draw a hard line between the actual medical terminology here.
Right, because words matter.
Exactly. So vaginal laxity is not an anatomical, structural medical diagnosis.
Wait, really? It's not.
No, it's actually defined as a subjective, patient-reported sensation. It is the feeling of looseness, a perceived reduced tone, or, a lack of physical friction during intimacy.
Okay, so it's a feeling, not a structure.
Right. The sources note it is often linked to the opening of the vagina, but it is entirely based on sensory feedback to the brain, what the patient feels.
Okay, whereas anterior wall weakness is a physical structural reality.
Yeah.
It falls under the umbrella of pelvic organ prolapse, and specifically, the sources refer to this as a cystocele.
Yeah, cystocele. And that occurs when a very specific internal support structure fails.
Walk us through that. What is failing?
Well, to understand this, imagine the pubocervical fascia. This is it's a tough fiber sheet of connective tissue that basically acts like a wall separating the bladder from the vaginal canal.
Like a load-bearing wall in a house.
Exactly. And when that fascia, along with the surrounding pelvic floor muscles, sustains microtraumas or just weakens over time, the wall essentially gives way.
Oh, wow.
The bladder, which sits right above and in front of the vagina, literally bulges down and pushes into the front vaginal wall.
Okay, let me try to make this visual for everyone listening. If you picture the pelvic floor muscles as a supportive fabric hammock holding up your internal organs, vaginal laxity is simply the sensation that the hammock's fabric has lost its tightness.
Yeah, like it just feels a bit baggy.
Right, baggy. But a cystocele, or anterior wall weakness, is like someone placing a heavy bowling ball, the bladder, right into the middle of that hammock.
Yes, exactly.
Causing the structure to visibly sag and bulge downwards under all that weight.
That imagery captures the mechanics perfectly. And according to the International Continence Society and IUGA terminology, these two conditions should present very differently in a clinic.
How so?
Well, a structural prolapse is generally reported by patients as a physical bulge, a heavy dragging sensation, or, the feeling of something actually coming down.
Right.
Vaginal laxity, on the other hand, is reported strictly as reduced sensation or looseness.
Which brings us to, the core mystery of the research stack.
The big contradiction.
Yeah. If a cystocele involves a literal organ, a heavy bladder bulging into the vaginal space, how could that possibly result in a feeling of extra space or looseness?
It seems completely counterintuitive.
Logically, if you drop a bowling ball into a hammock, there is less empty room in that hammock. You would think the space would feel tighter or even obstructed.
What's fascinating here is that the clinical data reveals a biomechanical illusion.
An illusion.
Yeah, it comes down to how the vaginal canal actually maintains its structure. You see that the vagina is not a hollow, rigid tube like a PVC pipe.
Right, it's not a fixed cylinder.
Exactly. It is a potential space, meaning its walls typically rest against each other, held taut by the dynamic tension of the pelvic floor muscles.
Okay, I'm following.
So when the anterior wall weakens and the bladder drops, it acts like a wedge. It compromises the overall structural integrity of the canal.
So it is actively forcing the resting walls apart.
Yes, exactly. The downward pressure of the bladder increases the overall vaginal caliper, which is the physical diameter of the canal, particularly widening the introital area at the opening.
Okay, so it physically gets wider.
It does, but more importantly, the surrounding pelvic floor muscles are stretched. They completely lose their ability to contract effectively.
So they lose their grip.
Precisely. The clinical sources show that with a mild to moderate anterior prolapse, the primary disruption is to this muscular tension. Without that baseline tension, the vaginal walls are no longer structurally taut.
And when you lose that tautness, what happens?
When you lose that tautness and increase the physical diameter, you get a severe decrease in physical friction. And the nerve endings in the vaginal tissue, well, they rely on friction to send signals to the brain.
Oh, I see.
When those nerves do not register contact, the brain interprets that lack of input as, well, too much space.
That is wild. The brain is essentially sounding a loose alarm because the physical grip is gone, even though there is literally a bulge taking up space.
Right. It's a sensory misinterpretation based on mechanics.
That completely reframes how we think about pelvic floor symptoms, but I feel like it also creates a massive problem.
It really does.
Because if a patient feels loose because their pelvic floor tension is destroyed by a prolapsing bladder, they go to their provider and say, I feel vaginal laxity.
And this is where we hit a massive diagnostic blind spot.
Yeah.
The clinical guidelines highlight a severe problem in routine gynecological care. Providers often completely miss the structural prolapse solely because of the tools they are using to conduct the exam.
Here's where it gets really interesting.
It is referred to in the clinical world as the speculum effect.
The speculum effect. Okay, break that down for us.
Consider a standard exam. The provider inserts a traditional full metal or plastic speculum, which looks a bit like a duck's bill, and opens the two blades to see the cervix.
Pretty standard procedure.
Right. But those blades physically press outward against the vaginal walls. The top blade of the speculum acts like a rigid shelf.
Oh, wait.
Yeah, it physically pushes the prolapsed bladder right back up into its normal anatomical position.
No way. It is like using a thick wooden shoehorn to check if a pair of shoes is too big. The tool you are using is literally filling the empty space, masking the very problem you are trying to measure.
That's a great analogy. The tool meant to diagnose the bulge is actually hiding the bulge.
That is incredibly frustrating.
So the provider looks inside, sees the vaginal walls held perfectly tight and in place by the plastic blades, and tells the patient, hey, your anatomy looks completely normal. You were just experiencing some subjective laxity.
So what are they supposed to do? How do you actually diagnose it?
To properly diagnose an anterior wall prolapse, the guidelines are incredibly specific. A provider must use a half speculum.
A half speculum?
Yeah, it only has a single downward blade. This retracts the back wall to give visibility, but leaves the front wall entirely free so they can actually see if it is bulging down.
That makes total sense. And they cannot just do this while the patient is lying flat on their back staring at the ceiling, right?
Right. Gravity is the completely missing component in a standard exam. Providers need to test in the supine position lying down flat, and then they must test the patient while standing up.
Standing up?
Yes. And crucially, they also have to ask the patient to perform the Valsalva maneuver.
Ah, the Valsalva maneuver. That is when you bear down like you're trying to pop your ears on an airplane or lifting a heavy box.
Exactly. By bearing down, the patient creates intra-abdominal pressure.
Which simulates real life.
Right. This mimics the physical stress the pelvic floor experiences during daily activities like coughing or exercising. Only by recreating that downward pressure without a top speculum blade in the way can a provider actually see the bladder push into the vaginal space.
This massive disconnect between the lived experience of the patient and the visual evaluation of the doctor is perfectly captured in the developed study from our stack.
Oh, the developed study is brilliant.
I was reading through the methodology, and they took 95 sexually active women and had them fill out the vaginal laxity questionnaire, or VLQ.
Right, the subjective questionnaire.
Exactly, to score how loose or tight they felt on a daily basis. And then urogynecologists examined these exact same women using a highly standardized metric called the pelvic organ prolapse quantification system, or POPQ.
The POPQ is basically the gold standard for visual anatomical measurement in this field.
So they use a ruler, right?
They literally use a ruler to measure specific points of the vaginal wall relative to the hymen. They also measure the genital hiatus.
What's that?
That is the physical anatomical gap between the pelvic floor muscles measuring from the urethra down to the perineum.
Okay, so you have a deeply subjective survey about the sensation of friction, measured directly against an objective ruler looking at the physical opening.
Exactly.
And the results are completely wild. The researchers found absolutely no significant correlation between the VLQ scores and the objective POPQ exams.
None at all.
They also found no correlation with the measurements of the genital hiatus.
It's mind-blowing. A woman could have a physically widened genital hiatus on paper and measurable prolapse, yet report absolutely no feelings of laxity whatsoever.
Wow.
And conversely, a woman could score herself as feeling incredibly loose, dealing with this frustrating sensation every single day, and that a doctor's ruler says her physical gap is perfectly within the statistical norm.
It definitively proves that the complex sensory feedback loop of the vagina, how the nerves perceive friction and tension, is far more nuanced than a simple ruler measurement. But, okay, if the speculum isn't hiding a bulge and the anatomical measurements are completely normal, why is the brain still sounding that loose alarm?
That is the next layer of the mystery.
That forces us to look beyond the muscle and the organs and look at the actual fabric of the vagina itself.
We have to look at the cellular level. And this brings us to a completely different physiological process, menopause.
Right.
Specifically, a condition formerly known as genitourinary syndrome of menopause, or GSM.
I noticed the sources point out this used to be called vulvovaginal atrophy, which sounds, frankly, terrifying.
It really does. But GSM is the modern, more encompassing umbrella term.
Okay.
GSM covers the widespread changes that occur as a woman's estrogen levels drop during perimenopause and menopause.
And estrogen does a lot more than just regulate periods, right?
Oh, absolutely.
Right.
Estrogen is not just a reproductive hormone. It is vital for maintaining the structural integrity of pelvic tissues.
Oh.
Well, it promotes collagen production, which gives tissue its bounce and stretch, and it maintains robust blood flow. When estrogen drops, the tissue basically undergoes a radical starvation process.
The physiological changes described in the clinical texts are just stark. The lining of the vaginal canal becomes significantly thinner.
Much thinner.
It actually pales in color because that rich blood supply diminishes. And most importantly, it loses its natural folds, which the medical texts call rugae.
The loss of those rugae is a critical mechanical failure.
Explain the rugae for us.
Think of rugae like the pleats in an accordion. Those folds allow the vaginal tissue to comfortably expand and then powerfully recoil to grip.
Okay, I see.
Without the rugae, the tissue loses its mechanical elasticity entirely.
Going back to our earlier visual, if a cystis cell is a bowling ball breaking the supportive hammock, GSM is like leaving the fabric of that hammock baking in the hot desert sun for 5 years.
That is a perfect way to picture it.
The overall mounting points of the hammock might be perfectly strong, like the muscles are fine, but the material itself has dried out, become brittle, and completely lost its ability to stretch and snap back.
Exactly. And the tissue loses its ability to naturally lubricate, leading to what some clinical literature vividly describes as cactus dryness.
Cactus dryness. Yikes.
Yeah, it's severe. Because the tissue cannot expand, stretch, or provide a smooth, lubricated surface, intimacy becomes incredibly uncomfortable. The sensory nerves are essentially sending stress signals instead of pleasure signals.
So how does that relate to laxity?
To the patient, this total lack of comfortable friction and physical responsiveness translates mentally as vaginal laxity.
Even though their underlying pelvic floor muscles could be incredibly strong, like a woman could be doing squats and targeted pelvic floor exercises all day, but because the surface tissue is sun-baked and inelastic, the brain still registers a lack of physical grip.
Precisely. The sensory feedback is misfiring. The brain says, I am not feeling the normal tension and friction, So it incorrectly assumes the physical space must be too wide.
Which makes getting an accurate diagnosis incredibly high stakes.
It really does.
Because an anterior wall weakness, physical muscle trauma from childbirth, and genitourinary syndrome of menopause can all trigger the exact same subjective alarm bell of laxity in the brain.
Right. They feel identical to the patient.
But the treatments for these conditions have absolutely nothing in common. If you have GSM and you treat it like a muscle defect, you are going to be endlessly frustrated.
You'll get nowhere. Let's break down the treatment pathways outlined in the clinical guidelines.
Yes, let's do that.
If a dynamic standing exam reveals that the laxity sensation is indeed caused by anterior wall weakness, like the bladder compromising the tension, the first line, evidence-based treatment, is pelvic floor muscle training, or PFMT.
And the sources are very clear that this does not mean just squeezing randomly while waiting at a red light.
No, absolutely not.
The guidelines recommend highly structured, guided training, ideally under the supervision of a pelvic floor physical therapist.
The supervision is vital. Clinical studies show that up to 70% of women who attempt Kegel exercises on their own actually perform them incorrectly.
70%.
Yeah, they end up bearing down, clenching their glutes, or tightening their abdominal muscles.
Which completely misses the point.
It completely ignores the pelvic floor and can actually make a prolapse worse by increasing downward pressure.
The stack mentions several tools to help build that mind-muscle connection, like the NHS-approved Squeezy app.
The Squeezy app is great.
Yeah, it guides you through specific contraction and relaxation timings. But beyond physical therapy, if the structural bulge is too significant and needs immediate mechanical support, the guidelines heavily endorse vaginal pessaries.
Pessaries are fantastic tools. They are removable silicone devices inserted into the vagina to physically hold the prolapsing organ in place.
I was looking at the designs for devices like the Uresta or the Contiform in the research. It is essentially an internal sports bra for your pelvic organs.
An internal sports bra. I love that.
You can insert it before going for a run or lifting weights to provide that necessary structural support to the bladder, and then simply remove it when you are done.
Exactly. By physically pushing the bladder back up, the pessary instantly restores the resting tension of the vaginal walls.
Oh, because the wedge is gone.
Right. For many patients, managing the physical bulge immediately resolves the sensation of laxity because the muscles can finally grip again.
Okay, but what if a provider determines there is no prolapse and the diagnosis is GSM?
Then the treatment pivots entirely.
Right, because you cannot fix a hormone deficiency by flexing a muscle. Doing thousands of Kegels is not going to rehydrate the sun-baked hammock fabric.
That's right. If the root cause is cellular estrogen starvation, the primary, heavily researched treatment is local vaginal estrogen. This is delivered via very low-dose creams, tiny dissolvable tablets, or flexible silicone rings placed directly into the vagina.
It is really important to distinguish this from systemic hormone replacement therapy, or HRT, right?
Crucially important.
Because a lot of women hear the word estrogen and immediately worry about outdated cancer scares associated with oral pills.
Yes, and local estrogen is fundamentally different. It uses a microdose that stays precisely where it is applied.
It doesn't travel through the whole body.
Barely. It acts locally on the vaginal tissue to rebuild the cellular structure without significantly raising the estrogen levels in the rest of the bloodstream.
That is a huge relief.
It really is. It literally thickens the lining, brings back the blood flow, rebuilds those crucial rugae folds we talked about, and restores the natural, healthy acidic pH by encouraging good bacteria to return.
That's amazing.
By healing the tissue quality, the natural lubrication and elasticity return, the nerves begin sensing friction properly again, and the feeling of laxity often just vanishes.
Okay, but we have to address the massive elephant in the room regarding treatment.
The quick fixes.
Yeah. When women feel this sensation of looseness, they often turn to the internet for answers. And they're immediately bombarded by very glossy, aggressive marketing for these quick fixes.
We are talking about energy-based devices, lasers and radiofrequency wands that promise, quote-unquote, non-surgical vaginal tightening.
Right, and they are everywhere.
This raises an important question regarding patient safety. Are these heavily marketed, highly expensive cosmetic treatments actually effective? And more importantly, are they safe for the delicate tissues we've been discussing?
And the clinical consensus across multiple global health authorities leans heavily toward extreme caution.
Caution is putting it mildly.
The warnings in the documentation are genuinely alarming.
To understand why they are alarming, you have to look at how these devices actually work. Lasers and radiofrequency wands operate on the principle of controlled thermal damage.
Wait, thermal damage, like burning?
Yes, they intentionally inflict microburns on the vaginal tissue, with the theory that as the body rushes to heal these burns, it will produce new collagen and tighten the area.
But if we are talking about a patient with genitourinary syndrome of menopause, someone whose tissue is already paper thin, incredibly dry, and starved of blood flow inflicting thermal burns, sounds like an absolute recipe for disaster.
Health authorities agree with you. Currently, the National Institute for Health and Care Excellence, known as NICE in the UK, has labeled these laser treatments for vaginal symptoms as investigational.
Investigational, meaning not proven.
Right. This means the clinical trials do not demonstrate enough long-term efficacy or safety for routine medical use.
And in the United States, the FDA took it a step further.
They did.
They issued explicit safety communications warning against the use of energy-based devices for vaginal rejuvenation. They specifically highlighted severe adverse events like burns, deep scarring, and persistent chronic pain during intimacy.
And the global pushback is growing. Australia's medical regulator recently conducted a massive review of the clinical evidence.
What did they find?
They took the drastic step of completely canceling the regulatory approvals for all these vaginal rejuvenation devices due to a profound lack of evidence supporting their marketing claims.
Wow. Canceled completely.
Completely. The overarching consensus in the medical community is to treat the root cause, not the symptom. If the muscle is weak, train it or support it with a pessary.
Right.
If the tissue is starved of estrogen, replace the hormone locally. Do not attempt to burn atrophied tissue into tightening.
That is such crucial advice. We have covered a tremendous amount of anatomical and diagnostic ground today.
We really have.
So let's explicitly answer the core question of our mission for you, the listener. Can anterior wall weakness, a prolapsed bladder, actually feel like vaginal laxity?
The answer is an absolute yes.
Yes. Because the physical weight of that organ compromises the internal structure, destroys the natural muscle tension, and alters the caliber of the canal, completely robbing you of that feeling of support and grip.
However, as the diagnostic day proves, that exact same subjective feeling of laxity can also be the result of a perfectly normal-looking pelvic floor that has simply lost its estrogen supply, changing how the nerve endings perceive friction.
So, what does this all mean? It means your physical sensations are entirely valid. If your brain is telling you there is a loss of support, you are not making it up.
You are definitely not crazy.
But it also means you cannot settle for a standard 5-minute exam with a full speculum. You have to advocate for yourself. You must demand a dynamic, comprehensive physical exam.
I'm requesting a half speculum.
Yes, testing while you are bearing down and testing while you're standing up. You need to figure out the specific mechanical or chemical reason why you feel that way.
I want to leave you with a final, broader thought to ponder based on the studies we've analyzed today.
Let's hear it.
The entire medical framework for pelvic floor health currently relies heavily on objective visual tools, like the POPQ ruler, to stage and validate a patient's condition.
Right. The seeing is believing model.
Exactly. But if rigorous studies like developed prove that a patient's profound, daily lived reality of laxity does not correlate with those visual measurements at all, well, is the medical community's reliance on what the doctor can strictly see fundamentally flawed, simply because it ignores the complex reality of what the patient actually feels?
That is the ultimate question. It brings us right back to our broken X-ray machine. Sometimes the jagged line isn't on a film. It is found in the lack of friction, the loss of tension, and the actual health of the tissue itself. Trust your body's signals, find a provider who looks beyond the speculum, and do not stop asking questions until your lived reality matches your clinical diagnosis. Thanks for taking this deep dive with us.